I'm Dr. Jason Altman. I'm a board-certified plastic surgeon in Coral Gables, Florida, suburbs of Miami. I have a practice focused primarily on rhinoplasty and breast surgery with ancillary focuses on body contouring as well. I've been in this location in Coral Gables for about 4 years now and in practice for almost 10. We decided to bring in BodyTite and FaceTite into the practice here in Miami because there's a growing demand in the community and I think in the world as well for less invasive, more effective procedures. Given our location and the volume of our practice, we're courted often by various sales reps trying to get us to incorporate their products, and I'm very hesitant and reluctant to bring something into my practice unless I really know it works and adds value. Especially in this community where patients are really excited and not afraid of surgery, a non-invasive product really has to demonstrate a substantial result to make it worthwhile. And BodyTite was really the first product I'd come across that had shown those results to both me and my patients, giving us the ability to tighten skin, which is a buzzword, but it's one that gets patients super excited. You know, if you can tell them you can tighten skin without scars, and now you can start bringing in other aspects of patients to your practice that really would not want to have a surgical procedure, arms, legs, necks, things that the surgery involved produces pretty large scars, pretty large downtimes. Now I can get patients in, treat them in an hour, get great results for them. That was sort of the breaking point for us to invest in something that we wanted in our practice. BodyTite has brought a lot of benefits to our practice, and when I talk to people about it, I tend to break it down into a three-factor modality. The first and probably the primary use of it for me is as an ancillary or quote-unquote upgrade procedure with liposuction. At this point, virtually all, 90+% of the patients that come to my practice and are offered liposuction as a treatment modality are also offered BodyTite along with it, with the exception of that very young 18 to 20-year-old patient that hasn't had any children, hasn't had any weight loss, and just needs very low volume liposuction. Almost anyone else can benefit from the addition of some tightening along with their liposuction, especially when we're doing arms or legs or back where you don't get as much tissue tightening as you do in the abdomen. So as an add-on to liposuction, it's an amazing, both in terms of patient satisfaction as a revenue generator. The second mode that I use it a lot in is as a primary treatment procedure in patients that either don't want surgery or don't necessarily need surgery yet. There I'm using it a lot in the face and neck. Patients don't want facelifts. Men don't want the downtime or the scars associated with that. This is a great 30-minute procedure. Go back to work the next day, local anesthesia. So it adds a whole new patient population to our target audience that we can offer things to now that in the past we really only had surgery to offer them. And then the last group is it's great to salvage cases in your practice. It's great as a touch-up. You have a patient that doesn't have a perfect result or that might have had a procedure done somewhere else and doesn't have an ideal outcome. Or you've done a facelift and there's still a little mild laxity left in the neck. We've all had those patients that still have a little looseness up here. Post-abdominoplasty, they may have a little upper abdominal laxity. This is a great way to convert that patient from someone that might be moderately happy or even mildly unsatisfied into a really happy patient with a very minimal procedure that has very little cost to you and very little downtime to the patient. Morning.
Hi, good morning.
Good. You ready? Excited?
I am.
Okay, awesome. So today we're going to be doing neck tight and face tight, right? So we're going to be introducing a little small electrode under the skin to tighten up the tissue here in the neck, the jowls, and the lower part of the face. Okay. So let's start by marking the areas, okay?
Okay.
I'm going to draw all over your face, okay? I'm going to be marking out both where I'm going to get my access from, okay, as well as the areas we're going to treat, and I'll put a few marks on there to remind us where some of the important structures are. Okay, we know where they are, we won't hurt them, but we want to make sure everybody else does as well. Okay?
I'm good.
Okay, so look straight ahead for me. Try to relax your neck a little bit. Good. And we're going to start by just marking out where that area that bothers you is, as well as the lower border of the mandible. Okay, we're going to come and circle around the jowl where we're going to treat. And because there's a little more tissue there than the rest of the neck, I outline that. It allows me to know that I can deliver a little extra energy to that area. Same thing over here. I always make it a point to palpate for the facial artery, and you know that's where your nerve is going to be crossing above. And we'll just mark that out as well. Okay. So we're palpating the facial artery so we can identify where the marginal branch of the facial nerve comes up over the mandible. That's an area. We can still treat that area. We just need to make sure that we are safe over it in terms of maintaining our depth. Okay, and then we're going to treat the lower face as well. So I'm going to take a line from somewhere around the root of the helix or the tragus out to the oral commissure. Same thing on this side. And you can kind of follow the natural curve below the cheek pad here. And then the last thing we're going to mark is we're going to take an approach to the oral commissure as well to try to get this jowl area here. Tighten that from both directions. Again, you can see we're coming over that area where the marginal is, and so we just always want to keep in the back of our head to be aware where that branch is. Lift your neck up for me now. I'm going to divide the neck into sections. I tend to divide it depending on how much I'm planning on delivering. I split the midline, and then often I'll divide into an additional wedge here and here. I think on her we're going to be fine just like that. We'll mark a little access point behind the ear. That'll give us access to this area, and then we'll come in through the oral commissure as well. All right?
All right.
Any questions?
No.
No? Feeling good?
Great.
Okay, she's received 1 milligram of lorazepam sublingually. We'll probably give her an additional dose. Most of my patients receive oral sedation for this. Some of them opt not to. They all tend to tolerate it fine. The tumescent really does a good job of numbing up. So we will lay her down. I'll inject and infiltrate her with the tumescent. Then one of my assistants will come in and prep while we're giving that time to work. It is important, especially when they're awake, to really give your tumescent a good, I know it's hard to wait the time, but give it a good 7 to 10 minutes to kick in. You'll see blanching of the skin and you'll know you're good to go. Okay?
Yep.
And Gab's just bring me a 20 cc syringe as well. So we're going to start injecting the local. What I do is I pre-inject the incision sites with straight 1% lidocaine with 1 to 100,000 epinephrine, little 30 gauge needles so they don't feel anything. And then for the infiltrate, depending on how much volume I need, I'll either use the regular tumescent solution, 500 or 1,000 of normal saline with 50 cc's of lidocaine and 1 amp of epi. Or in this case, since it's a more focal region, I'm using something a little more concentrated. So with her, we're going to use 0.5% lidocaine with 1 to 200,000 epinephrine. And I'll just inject that with a spinal, 22 gauge spinal needle. In someone like this patient, where there's very little submental fat, I don't plan on doing any liposuction on her. But the infiltration is really important because not only is it obviously going to provide the anesthetic, but it's going to give us a little bit of depth. You know, we want to be able to keep our cannula tip a minimum of 3 millimeters below the surface. And in someone this thin, sometimes that can be challenging. So the infiltrate will allow us to thicken that subcutaneous tissue. So you're going to be really generous with it. And if you feel that, you know, you're getting close to your lidocaine maximum, you can always just mess with a little extra normal saline if you need a little more thickness there. With the small cannula, you can gain access with a 14 or 16 gauge needle, or you can use an 11. I find that the 11 is just a little more precise. You get a linear cut instead of a round one. And because we're not doing suction here, I'm still going to undermine with a very small liposuction cannula. We're going to make our first access, just the very tip of the 11. I'm just making enough space that I can get through with my lipo cannula. And I use a really small, I have like a 2.4 millimeter lipo cannula. Sorry, my hand is covering it, but for safety, you always want to be kind of feeling the tip of that cannula. You can see where we are depth-wise. Okay, there's a good layer of tissue above us. So the face cannula, internal, external. You can see this is flexible, so it's nice. You're not going to damage anything with it, but that's where you need to always just sort of be aware of your tip position, right? Because you can get some yaw out of this, where you get lateral motion, and you really want this centered over the external temperature sensor, and you can get flexion. So if you're torquing, you can wind up with your tip a little too close to the surface, and you'll see that once we introduce it. Okay, so we are set to 38 on the external. Our internal is set to 65. That's definitely the highest you want to go in this area, and I would work your way up to those numbers. We're going to set our treatment time to 120 seconds. That's a safety precaution. That just means you have to take your foot off the pedal every 2 minutes. It's a way of making sure you're not falling asleep during the procedure. The machine's now out of standby. The first thing I do every case is I test these hand pieces. I'm going to pinch the external, and we're going to look for a rise, on the internal temperature. You can see it very quickly responds. I then test the external sensor, make sure that rises, and both of those are functioning, so we know we have our safety measures in place. I'm going to apply, that's sterile ultrasound jelly. Cools the skin and assures a good contact between that external sensor. This is what we use here, sterile aquasonic. It comes in 100-gram packets. I keep them cool. It helps pre-cool the skin. You can also use them during the procedure. If your external temperature is getting hot and you haven't reached your goal internally, this will cool that skin off and protect it while you can continue to deliver energy to the deeper tissues. Okay, and we're going to treat in zones. So we're going to come up. You can see from our pre-tunneling now that the cannula really moves fairly easily through the tissue. Okay, and again, when I first did these, I would try to do everything through a single access point. The access points are so small, you're much better off with additional access points, especially in curved structures like the neck. What you don't want to get into is a situation where you're torquing like this and your tip is getting too close to the surface, right? You always want to be down and uniform. One of the nice things about this machine is they've done a really good job with the tonal alerts. You will learn very quickly what they mean, and so you'll be able to focus on the patient instead of constantly looking at the numbers on the machine. Okay, so again, I'm just still pre-tunneling a little, making sure I'm not going to run into any hang-ups anywhere. And we're going to come up into the jowl from this access point, and that's where we'll start. Okay, so looking at our depth, we have a nice layer of tissue coverage. We're going to close down over the tip, and you'll hear the pedal. What I'm going to do is I'm going to, on that initial contact, let my temperature rise close to my goal, and then I'm going to start withdrawing slowly. You'll hear the beeps increase as we get to temperature. And now we'll start withdrawing with our goal. I'm going to be quiet so you can hear the sizzle. Our goal is to keep it as close to our temperature goal without hitting it. Remember, once you hit goal, your energy is turning off, and so you're no longer delivering anything. So now we'll move down to the next level. So just sort of mark yourself that 1 to 2 centimeter margin of safety, and you know not to come back and cross there. Kilojoules to the neck. I don't base my treatment on energy at all. I base my treatment on temperature goals. But I use my energy for symmetry purposes. So although I'm not looking at how many kilojoules I'm delivering while I'm treating, once my treatment is done and I've reached my temperature goal here, I know I'm going to be right around that 1.1 kilojoules on the other side as well. Okay? I'm just going to come around for a little better access. You're doing great. You're tolerating this okay?
Okay.
Any pain at all?
Mm-mm.
You feel any warmth?
No.
No, good. So if you touch, you can feel definitely a significant difference in skin surface temperature on the side we've treated versus we haven't. And if you look, our straight line has become curved, and we've definitely pulled tissue in this direction here. So we've now delivered equal amounts of energy to both sides, and now I'll just do a visual assessment for symmetry. If I see any areas a little fuller on her, I feel like there's a little extra fullness here, and I'll just come in and do some localized treatment over that area for symmetry. I tend to do my suctioning first. You can come in now, suction out your hot oil. What I will always do to make sure it's not pooling there is I'll just take a moist gauze and roll anything out. She has virtually no fat in there, so we're not going to see a lot of that coming out. But any fluid that collects is easy to milk out. can see we're moving a little faster here than we did in the neck. With the thinner tissue coverage, you're going to get your temperature rise a little quicker. Just inside the oral mucosa on the commissure. And that's it, same thing, you want to just make sure you're under my head. Here we're going to really just do a quick little, I'm going to stay away from the nerve, okay? When we're all done, the stab incisions really don't need any sutures. Sometimes I'll put a little 6-0 in the neck if we need to. These are small enough that we'll just close them with little steri strips and be done. And then the girls will apply a little pressure dressing. I tend to do some like toppy foam, lipofoam, whatever you want to call it. There's a million different brands. I'll lay that over any areas and then a typical sort of facelift sling bandage. I try to get them to wear it as long as possible. The more compression you give them, the better. I find with the faces, compliance can be difficult, but I really stress to try to get them to keep this thing on at least 48 to 72 hours round the clock, and then if I can get them to wear it when they're in the house for the next week or two. She'll be able to walk out of here on her own, and tomorrow, if she wanted to, she'd be able to go to work. There's very little post-op pain. I always prescribe them some low-dose narcotics, so they have it. If we're not doing lipo, just a little Tylenol 3. Most of the patients don't take it. They get away with Tylenol. This does such a good job of hemostasis that I'm not worried about giving them NSAIDs either. So I let them take Motrin or Aleve after the procedure. If I'm doing more aggressive liposuction or other surgeries with it, I'll have them hold off the NSAIDs, but otherwise no problem. In the face, we'll do some sort of viral prophylaxis if they have a history of cold sores. And that's it, hon. Okay. You may notice a little weakness in the nerves from the injection. Smile for us. Big smile, big smile. So you see she's got a little weakness in her corner, totally expected. She's got motion there. That doesn't appear to be any type of nerve injury at all. That'll wear off as the anesthetic wears off. Can you blow a kiss? Perfect. Okay.